Heart disease and stroke are a major cause of death in many parts of the world and in Ghana today, accounting for over 40% of deaths in many lower and middle income countries. My guest is a renowned interventional cardiologist who left Ghana over 35 years ago and returned recently to practice. What does he make of the state of medical practice in Ghana today? Back in a moment. Dr. Nicholas Ossei, Gerning, welcome to Time with David.
Thank you. It's good to be here.
Doc, in my introduction, I was referring to, the bane, if you like, of cardiovascular illnesses and so on, and how serious it is. As I understand it, it's a bigger problem in our parts of the world. Is there a reason why that is the case?
Sure. Well, first to say the irony is that many people actually think of heart attacks and stroke as being the disease of the white man. And of course, that's completely wrong. In fact, if you look at the most recent data published only yesterday, in fact, it demonstrates that in high-income countries, heart attack and stroke, cardiovascular disease, accounts for about 27% of deaths in those in high-income countries.
Has it been declining? Has it been declining?
And it has been declining, exactly. Compared to 42 and 43% in middle and low-income countries,
including Ghana.
Including Ghana. So it's a bit of a myth, and the reasons for that are protein, but it ranges from you will have to look at the risk factors for heart attack, and also how that is managed. So it's both and. Yeah. So if you look at risk factors such as hypertension, well, the big six are family history, which you can't do anything about, and then it's hypertension, dyslipidemia, obesity, smoking, diabetes, and hypertension, if I didn't mention that. So it's those are the big six. So if you look at all these risk factors, certainly if you look at hypertension and stroke, hypertension and diabetes, forgive me, it's far commoner amongst black people compared to our Caucasian.
Why is that
counterparts?
Why is that?
It's that's also. If you look at the risk factors, it's also the result of what we call gene-environment interaction. So it's abnormal genes and as well as environmental factors. So it's diet, it's exercise, it's alcohol intake, etc. But these things, all these risk factors interact, and if you look at the way Ghana as a society, a lot of things are societal issues. Our diet reflects.
Diet is big.
Our diet's big. Our lack of exercise.
Meaning what? That our food is unhealthy.
Yes.
Or the way we cook. No, let's be clear, because if you say our food is unhealthy, you'll be in trouble. Kuntumbre, a lot of garden eggs, a lot of veg in our food. Sure. How can it be unhealthy?
So I don't want to get into the cul-de-sac of describing in detail about dietary matters, and I'm no expert. But when you look at the recent and indeed past trials, you can summarize the Mediterranean diet as being the best in terms of foods that are high in vegetables and fruit, and the issue about amount of fat has been debated more recently.
Right.
But
about how you cook food.
And very high carbohydrate diet is also not great. So our food tends to be very high in carbohydrate, and that's not meant to be great for you.
I hear you.
But it's also quantities. It's also the amount.
Yes, it's also the amount.
It's also the amount that you
eating a lot of food.
Yes.
Can we bring 42% down as well? You said that in the developed world, the trajectory is that it's going down. Is that our case as well, or are we steady on at over 40?
Well, if you look at the recent data, if anything, is going up. And it's going up, of course, because our these risk factors are not coming down. If anything, the epidemic of obesity and lack of exercise, poor diet, etc., is going up. So, in fact, whereas in the West, the rates of death from cardiovascular disease are coming down, in our sub-region, it's actually going up. But I really have to make this clear. It's not just because of the risk factors that lead to these diseases, but it's also how it's managed.
Yeah.
And how you manage disease
is a big part of it.
It's a huge part.
We'll come to that. Okay. I just want to wrap up with this first part, and we'll come to that.
Okay.
Just before we move into that, do you think that to address the problem, is this something that each of us must do something about, or is this something that a government ministry and department, say, health ministry, can be active in? Is there a place for governments in ensuring that the population is healthy and so on? Or is this just really up to each and every one of us to exercise more, eat better and so on? What do you say?
Well, it's a fascinating question, and it's really quite involved. But it's always going to be both and. It can't be either or.
One or the other.
So, as an individual, you've got to make sure that you're eating the right things, that you're exercising regularly, and there is very clear data as to how.
But government can encourage you
to.
too.
Well, of course. So your diet has to be good. You can't afford to smoke. If you're going to drink alcohol, it's got to be done.
So government can make cigarettes expensive.
I was going to come to the government bit in a second. Yes. But in terms of the individual, you have to look at all the components of these risk factors, and you've got to say, what can I do myself in order to reduce my risk of cardiovascular disease? It's got to be, I've got to exercise regularly, I've got to eat the right things, I've got to drink sensibly, I can't afford to smoke, my weight has to come down however I want to do it. And those at the individual level, each of us has to take responsibility.
Okay, that's
what
clear.
Can government do?
Yeah.
Well, government has to look again at all these components and say, how can we, what can we do? One of the interesting things about the paper that was published in the Lancet was about air pollution, and the role of air pollution has been air pollution has been a major risk factor. Well, that is government. You and I can do absolutely nothing about air pollution. Yeah. But it's going to be things like there can be legislation to affect amount of salt, amount of sodium for salt in food, about things like making sure there are more sports centers where people can exercise. I mean, there's a whole raft of things that government can do to intervene. Okay. I mean, we'll obviously talk about management, which is really, when it comes to managing this, the disease, that's really where government plays a major role.
So let's talk about management, okay? You said that was the other half of it. Mm-hmm. What exactly are we talking about when you talk about managing a disease?
Okay. I think the best way to deal with this is to think of a patient who is having a heart attack.
Yes.
For example, let's take that as an exemplar. So, patients at home starts to have severe pain.
Pain in the chest.
Pain in the chest. He's clutching his chest. What can you do? Well, if you're in the UK, which is a practice I'm used to, you pick up an ambulance and you phone, and the ambulance is going to get there usually within 5 minutes, and it's going to take you to it's going to go on roads that can get to the hospital quickly. Yeah. You're then going to get to a heart attack center, which is dedicated. You're then going to be taken to the cath lab, just like the theater, where you're going to be given medications that we know are going to help with a heart attack. You're then going to have an experienced practitioner who is going to unblock your artery that is causing the heart attack. You're then going to be taken to an ITU or either an intensive care or a coronary care unit. So in the UK, to be a coronary care unit, where you're going to have very experienced people looking after you. Right. Now, at each of that patient journey, we have a problem in Ghana. So it's...
You mean the ambulance is not coming
correct.
in 5 minutes? You mean the road carry on is not good?
Absolutely.
You mean when you arrive at the place, there's nobody? But tell me what you're talking about.
Yes, well, exactly. That's it. You're absolutely correct. Yeah. So the ambulance is not going to turn up. Yeah. The roads are clogged up, so you can't get there in time. Yeah. And by the way, managing heart attack in terms of mortality, in terms of death, is absolutely time dependent.
So you have to be quick about it.
It's got to be quick. And the longer you delay, the more likely you are to die, full stop.
Or you damage something even
the more likely you are to die.
Wow.
It is actually associated with
I
mortality.
hope it's just damage
No,
and
no.
not death.
Well, the two are linked.
Well,
The two are linked.
yeah,
Damage to the amount of heart damage that you cause is directly related to death.
Yeah.
And there are lots of studies to demonstrate that.
Yeah.
And of course, it does make sense. Yeah. So the roads are clogged up. And by the time when you get to a hospital, I mean, by the way, you need a heart attack center. Well, there are only two that I know of.
We have one
in Ghana.
at Kolebu.
There's one at Kolebu, and one at Eurocare. Now, Eurocare is the 24-hour service.
Yes, where
Kolebu,
you are, the facility that you run.
Correct. That has got a 24-hour service. So if you're lucky enough to get there and you can pay, then you can be managed. And you can be, so if you're in Takoradi where there is no center, so it's not only the problem with the ambulance and the roads clogged up, there is no heart attack center where you can have an experienced interventional cardiologist.
So when you get a heart attack in Takoradi, you die?
Well, you may do, of course, and a lot of people do. If you are lucky enough, you will suffer a significant heart damage, which of course is likely to shorten your life. But yes,
you'll be brought to Accra. You'll be brought to Accra.
You can be if you can afford it. If you are a member of WAR or whatever, and you can fly in, then obviously you're likely to be managed. But the point I'm making is, at each of these areas, that is a governmental problem. You and I can't do anything about an ambulance.
So
we can't do anything about the roads. We can't do anything about the fact that the roads, it's not just the bad roads, but the roads are clogged up. We can't do anything about the fact that there's only 2 heart centers, one private, one public, in Ghana.
It sounds terrible in a way.
Well, it is, and I think it's not only terrible; it's an absolute tragedy. Because I come from a system in the UK where it doesn't matter where you are. You pick up an ambulance, you'll be taken to a heart attack center where you're going to be managed successfully, and your life will be saved.
So we shouldn't even, in our case, maybe we should be making more of an effort not even to get a heart attack, because when you get it, it can't
Well, that is absolutely correct. Well, to be fair, it doesn't matter which part of the world you are. You've got to try very hard not to have one. And there's no doubt that prevention is always going to be better than cure.
How do you fix it? How do you fix it? You are the medical director of Eurocare, one of the 2 facilities you described. But I'm listening to you saying when you have some money. I mean, why? Let's talk a bit about that. I mean, this whole, almost like, I don't know what to call it, you buy life, you pay for. I mean, really?
Well, that's, for me, is one of the biggest difficulties in working in this system. Because I come from a system, I'm used to a system where it doesn't matter who you are, you can go to a hospital where you're going to be managed. Because we've got a national health system, which is a safety net for everybody, for all and sundry, rich, poor, ugly, beautiful, fat, thin. Doesn't matter who you are.
And driven underpinned by insurance, I presume?
Well, no, as you well know, the National Health Service is paid for. Obviously, it comes from our
taxes.
From our taxes.
Wow.
And our national insurance is paid for. As I understand it, there is the NHIL, I think it's in Ghana, which is supposed to provide for, but clearly that doesn't exist. I mean, well, it does exist, but it's woefully inadequate. Woefully inadequate. And
so that's how for people to be able to afford, healthcare. Really, that the state must be
the state. The way health is run has got to change fundamentally. In my view. I mean, it needs a massive amount of money to be infused into the system to emulate what the sort of a system like the National Health Care System in the UK, where there is a safety net for everybody. The NHS system in the UK is not the only sort of system that exists. There are others, for example, in the Canadian system, where you pay, it's basically a hypothecated tax. You pay a certain amount, comes directly from your tax base, dedicated to health.
Just funding health delivery in a creative way, so you can have the resources to provide a certain quality of service.
Correct. Yeah. But it's a system. It's got to be a system which is all-encompassing. I mean, what I dislike about the American system is that, if you're rich, you can buy health, and if you're poor, you're in trouble. It's got to be a system where there is a safety net for all.
Yeah. Dr. Ossei, when I was doing a little research on you also, I realized that one of the areas you're an expert is in erectile dysfunction. And clearly there's a link between that and heart disease. If there was a guy with erectile dysfunction, I could pretty much assume that he is a candidate for heart attack.
Well, we know that 75% of patients with erectile dysfunction have got cardiovascular disease, effectively. I mean, the two are that closely linked. And the risk factors that we aforementioned are the same risk factors for erectile dysfunction. And vascular disease, the cardiovascular system, your heart and all the blood vessels that supply all the various organs, when they start to clog up, depending on the system that gets clogged, you have the associated phenotype. Absolutely. So if it's the heart, you get a heart attack. If it's the brain, you have a stroke. If it's kidney, you get kidney disease. And of course, if you clog up your male organ, then you end up with erectile dysfunction. Because the arteries to the male organ is small, that tends to start clogging up first.
Quicker. Yeah.
And that's why very often when patients start to complain of erectile dysfunction, yes, it's a harbinger of heart disease.
Do you get often people with that? Do you find that you're treating that? It's almost like it's one of those things that sometimes I think people here might want to keep quiet over, not sort of reveal and so on. Are you right about that?
So I got involved in the whole area because a lot of patients who came to see me for their heart problems, on their way out, would say, by the way, doctor, I have a problem with this. And we know, we did a study in Cardiff demonstrating that 2/3 of all our heart patients had erectile dysfunction.
Wow.
And I was going to say, I run quite a big ED practice in the UK, and virtually all my patients who came to my ED clinic had, who'd had either heart attack or had stents put in their arteries or whatever. The vast majority of them had their erectile dysfunction before they had their heart attack. So the two are that closely linked. Yeah.
Many doctors very often are seen to be too cut and dry. I mean, you've done this so often, you just do it. You talk to patients and you come across like very often they feel like just another statistic. Do you agree that that's a problem?
Yeah, I mean, it can be. I don't think, doctors are human beings, and just as...
Which is why they should be more emotional.
But the point I was going to make was some human beings are emotional and others are not.
So the better doctors are the emotional ones.
Well, I think...
empathizing. I'm referring to, yes.
I think so. I think, for me, the best doctors, the best holistic doctors. Because, listen, when you have a doctor who is going to operate on you, you want the best doctor, whether they feel they're empathetic or not, or it's completely irrelevant.
Yes.
You want somebody who is going to do the best job. Yeah. But in terms of the way they deal with you at the psychological level and the emotional level, you want somebody who is going to be able to empathize.
Absolutely.
But at that level... it depends. I mean, different human beings. Doctors are just like. But it seems you get a full spectrum.
You say that, but it seems to be more something that you see more with doctors. Train outside as opposed to maybe doctors here. Is there a cultural element? I'm just saying that
there might be. Yes, there might be a cultural. There might be a cultural element. Yes, there's bound to be a cultural element in the way
come from a society where these are the facts and so on.
In the way people interact. Yes, there's got to be.
But you agree that a doctor that is empathetic, people also need hope, when they are unwell. I mean, I know the facts are the facts, but you don't want to let them go away feeling terrible, do you? I mean, as a good doctor.
I agree, and I would submit that the best doctors are the ones that would also be empathetic and think of the fact that we are, as a human being, you've got we are all psychological beings. We are all emotional beings.
Absolutely.
It's not just flesh and blood. Yeah, and so you've got to be able to deal with people at that level as well.
To wrap up, when I first heard of you, you had come to Ghana to, as they say, save a life. Some crazy trip where a friend was dying in many ways. And on a Saturday you got on a flight, and Sunday you were doing surgery, and so on. And I see when I research that subject that you look back on it sometimes and you think, my God, that was the very crazy thing to do. I shouldn't have done this. Now you've had a couple of years. This happened several years ago, so you can look back on it. Do you feel the same about what you did then?
Oh, I've no doubt that what I did then was entirely insane. The whole story was crazy, but it's very interesting to reflect. Now that I've been here for a while, and you know, I can see how it is that a lot of doctors are practicing without all the paraphernalia and without all the tools, and have to get on with it. And that is the reality of the life of a lot of
So you
a lot
appreciate
of doctors.
more now what Ghanaian doctors have to go through.
Correct, exactly. And you've got to respect that.
So surely, I mean, your view of medical practice must be shaped by all of that. I mean, you are critical of a lot of what we do here, aren't you?
Well, yes, I am. I mean, I am, because I'm used to working in a particular way, and I don't understand a lot of ways in which things are practiced here.
What is the one thing that gets you most, would you say?
Oh, dear
that you
Lord.
wish could be done differently for real in your business?
I'll give you an example. Well, I'll give you an example of so just yesterday I saw a patient who'd gone to a hospital with the clearest evidence of heart attack, and the patient had just been put on a drip and left. Went in on the Thursday morning. They did some blood tests on a Saturday, and it was only on the Monday that the patient was sent to us. You know, so in the UK, you are judged by how you intervene on the patient, how you open up the artery within 60 minutes.
So you're saying
within 1 hour,
quicker than they
Let's
did.
be clear, within 1 hour.
Right.
This patient had the heart attack early hours of Thursday morning and saw me on Monday morning.
Yeah, it's too late.
Well, it's not too late. It's insane.
Yeah.
And that is not, unfortunately, that is not an isolated example. I mean, I can say that, quite frankly, every heart attack I've had to intervene on has come in at, you know, several hours down the line, which gets me as an interventionist, you know, because, by the way, the quicker you deal with the patient, the easier the operation is. If the longer you leave it, the more difficult the operation is. Not only is the patient sicker, but the more difficult the actual operation of trying to unblock the artery is. That really gets me. Yeah. Stroke is another area. So we at Eurocare have started a hyperacute stroke management. So as soon as you get your stroke, you get to us, and we can either use clot-busting treatment to unclog the artery to the brain, or we try and open it using a clot sucker. Yeah. You know, the vast majority of strokes, well, all of them currently, will just be left for life to take its course. Yeah. I mean, that is unacceptable. I mean, and it's very, very sad. And I find that extremely challenging. If there's anything I get really emotional about, is the way we handle the biggest killer, heart attack and stroke in this country, is completely unacceptable.
So there's a lack of urgency. The lack of urgency.
It's a lack of urgency. It's a lack of, I don't know whether it's understanding. I don't know, but yeah, I mean, it's definitely a lack of urgency, and I find that extremely difficult.
Thank you for coming.
Thank you.
Such a pleasure.